Next, let's learn about the upper urinary tract infection. Upper urinary tract infections include acute pyelonephritis, renal pus, multiple renal cortical abscess, and perinephritis. We will focus on the acute pyelonephritis. Acute pyelonephritis is an acute bacterial inflammation of the renal pelvis and renal parenchyma caused by pathogenic infecting renal pelvis via bladder and further infecting renal parenchyma while renal pelvis are spreading to renal pelvis and renal parenchyma by blood circulation. The major pathogens of upper infection are gram-negative bacteria, mostly Escherichia coli and other enteric bacilli. The main pathogen infection, the urinary tract via blood circulation in gram-positive bacteria. This disease is more common in female than in male. Acute pyelonephritis is mostly manifested by fever, lumbago, and bladder irritation. The onset of acute pyelonephritis infected via blood circulation may be featured by shiver and high fever over 39 degrees, accompanied by headache, nausea, vomiting, and followed by urinary irritation symptoms. Patients often suffer from affected side or bilateral waist, distending pain, and obvious tenderness or percussion pain on costal spinal angle. The acute pyelonephritis can often be primarily diagnosed by medical history. Physicians need to specifically ask the patient for lower urinary tract infection, prostate inflammation, and infection other parts of the body. The white blood cell, red blood cell, urinary protein, and white blood cell count can be found in urine examination. In the urine bacteria culture, there are more than 4 power of 10 colonies per milliliter of urine. The white blood cell count increases and the neutrophil significantly increases, with septicopyemia occurring in a severe case. Additionally, X-ray, B-mode, ultrasound, CT, and other hematological examinations also help determine whether there is obstruction or disease of upper urinary tract. Supportive treatment of antibacterial therapy and alkaline drug therapy are used for the treatment of acute pyelonephritis. The patient is recommended to rest well, drink more water, and urinate at least 2,000 ml every day for the purposes of inflammation reduction and excretion of metabolite. The antibiotic drugs used include beta-lactamase and penicillin, which have a strong effect on gram-positive bacteria, and broad-spectrum penicillin such as ampicillin has obvious effect on Escherichia coli. The sulfonamides, quinolones, aminoglycoside, antibiotics, and vancomycin also work in the treatment. Alkaline drugs such as sodium bicarbonate and potassium citrate can reduce the irritation of the bladder by acidic urine and alleviate the symptoms of bladder irritation. And next, let's learn about the lower urinary tract infection. Acute bacterial cystitis, chronic bacterial cystitis, and acute urethritis are 3 most common cases of lower urinary tract infection. The acute bacterial cystitis is commonly found in female due to the anatomical and physiological characteristics of female urethra, and almost all the cases are caused by Escherichia coli via ascending route. The acute bacterial cystitis is often featured by sudden onset, and most cases of young women are related to their sexuality with manifestations of frequent urination, urgency of urination, urodynia, and urethral during sensation. The severity of the symptoms varies with patients, some with terminal hematuria, some with hematuria during whole process of urination, and some with blood clot discharged. The systematic symptoms is not obvious and featured by normal body temperature or low fever, and high fever only develops when complicated by other acute inflammations. It is not difficult to diagnose the acute cystitis according to the clinical manifestations of patients. A positive result can be usually obtained from the increase of white and red blood cells in urine and colonal counting and drug sensitivity test by urine culture. The sensitive antibiotics for treatment need to be selected according to the type of pathogenic bacteria and the results of drug sensitivity test. The antibiotic drugs may be sulfonamides, cephalosporin, and quinolones. Generally, the oral administration would work in the high-dose impact therapy in short period. The patient should drink more water and take sodium bicarbonate orally to alkalify urine and other drugs to reduce the symptoms of bladder irritation. Hot compress on bladder and hot water sit bath help to relieve cystospasm, and it is also necessary to actively treat various systematic or urinary tract disease that cause recurrent attack of urinary. As a common type of lower urinary tract infection, acute urethritis is the acute inflammation of the urethra, usually coexisting with acute cystitis at the same time, mostly spread by sexual contact and caused by gonococcus or non-gonococcus pathogen. The urinary tract infection caused by gonococcus often involves the mucous membranes of the urogenital organs. Gonococcus is gram-negative diplococci with the human body as its only natural host and susceptibility, reinfecting human upon hypoimmunity after onset. Gonococcus urethritis spreads mainly by sexual contact and sometimes spreads indirectly by trousers, towels, tubes, bedpans, and hands. It is usually featured by sudden onset, red and swollen mucosa at urethral orifice, itchy or stinging, a large amount of yellowish-white purulent secretion discharged from urethra manifested by symptoms of frequent urination and urgency of urination. Most patients have a clear history of unclear sexual contact. Incubation period 2 to 8 days, generally attack within 4 days. Symptoms alleviated after about a week of timely treatment with redness and swelling at urethral orifice subsided. Secretion discharge from urethra decreased and urination returned to normal. Symptoms disappears after 1 month. Chronic gonococcal urethritis may be caused if not treated timely or completed, leading to the urethral connective tissue fibrosis and inflammatory urethral stricture. It is not difficult to diagnose the case with typical clinical manifestations and history of unclear sexual contact as a pair of gram-negative Diplococcus can be found in multinuclear leukocyte in smear of urethral secretion. Penicillin is the main drug in the treatment, and cephalosporin, spectinomycin, and other drugs may also be used for treatment. At the initial stage of infection, 250 mg ceftriaxone is intramuscularly injected once a day for 3 times a day, and quinatones, cephalosporin, and sulfonamides are taken orally during one course of treatment of 7 to 14 days. In case of severe case, it is necessary to prolong the course of antibiotic treatment. In case of urethral structure occurring as a long-term complications, periodic dilating urethra should be mainly performed with applications of antibacterial drugs, and the extensive anterior urethra structure may be treated with direct vision internal urethrotomy under endoscope. The spouse should receive treatment at the same time and use condom to avoid the repeated infection.